This is one of the first studies where we're using positive ctDNA to assess and treat patients for an alternative adjuvant therapy. And because this is an exploratory study, our goal would be, first of all, to look for a signal, I suppose, in this group of patients. And if we see a positive outcome, as in we see a reduction in ctDNA for patients treated with Trastuzumab Deruxtecan, or even an improvement in overall survival, then we can expand to a randomized study. So a lot to date, a lot of the ctDNA assay work has been done in colorectal cancer, and there are less results in esophagogastric cancer. So one of the first large-scale analyses was done in the UK on a retrospective data set that I worked in when I was at Cambridge called Occam's, and in that we used one of the first-generation non-tumor informed assays, and we showed it at reasonable sensitivity, but it probably wasn't sensitive enough to de-escalate studies or to de-escalate treatment, and maybe detected about 20% of patients to be ctDNA positive, but we know that 50% of patients relapse. And subsequently, we have tumor-informed assays like Signatera, which I think is probably the best in class, the most recognized certainly in colorectal cancer. And we detect, historically in retrospective data sets, they've detected about maybe 25% of patients to be positive, but actually in our data set so far we've detected about 50% of patients to be positive, which is the proportion of patients that you would expect to relapse. So I think as we move forward, we will see increased sensitivity of assays. For example, we're seeing now Signatera being used with a whole genome rather than whole exome. And we also see the evolution of methylation-based assays that do not require tumor. So for example, in Garden testing. So I think what we need to do is consolidate those larger data sets. There'll be a nice one, I think, published from Japan later this year. And then we'll be in a position to say which is the best, if any. But I'm pretty satisfied with Signatera for now. Usually for perioperative chemotherapy for patients with esophagogastric cancer, we give 4 cycles of chemotherapy before surgery and 4 after surgery. After surgery, after an esophagogastrectomy, patients tend to be pretty tired. It is a life-changing surgery. And if you look at the studies that looked at perioperative treatment, about 50% of patients are not able to have all of that treatment after surgery. So it was a balance between efficacy and safety, comfort for the patient. If we look at the duration of adjuvant therapy, for example, in colon cancer and breast cancer, it tended to be between 4 and 6 months for cytotoxic chemotherapy. So we thought that that would be enough, hopefully, to show a benefit and possibly cure some patients without compromising safety and tolerability. Gastric cancer, HER2 is a well-established biomarker. HER2 positivity is different in gastric cancer compared to breast cancer, and that's maybe one of the reasons why we see slightly different results for HER2 targeting therapies in gastric cancer compared to breast cancer. On a biopsy, we only need 5 cells to be HER2 positive to designate the patient as HER2 positive, but because we have resection specimens in this study, we have a lot more confidence around the biomarker assessment. So we tend to see around 15 or 20% of patients to be HER2 positive, and we're satisfied that HER2-directed therapies, in particular T-DXd or Trastuzumab Deruxtecan, which we're using in this study, have a documented efficacy in that patient population. So in metastatic disease, we would expect about 40% response rate. Let's see if we see more or less than that using ctDNA assessment. So in the operative setting, we need to be pretty cautious because patients are feeling tired. Sometimes their nutrition is compromised after their surgery. So in the context of any clinical trial, we use CTCAE grading for toxicity. But more important than that, in terms of quality of life, what's important for patients after esophagogastric cancer surgery is attention to their nutrition. So most patients will be followed after surgery by a nutrition team or by their clinical nurse specialist. And in particular, we need to establish that patients are not continuing to lose weight, that they don't have post-op problems like dumping if they eat high carbohydrate meals. So this is something that if you're an esophagogastric cancer oncologist, we're very used to paying attention to whether or not the patient is on a clinical trial.